I would like to introduce Dr. Dirk Booysen. His topic is evidence-based medicine and optometry practice.
I'm Dirk Booysen. I'm from South Africa. I'm in private practice. I used to lecture at the university in contact lenses and pathology. At the moment, I'm concentrating more on private practice. I'm very passionate about therapeutics in optometry and the role of optometrists in actual fact primary care all over the world, and especially in South Africa. Because you've got people that are needlessly going blind.
Okay, it's perfect now.
Okay, so you can see the slide. Okay, let's see. There we go. That should be better. All right, so evidence-based medicine is the integration of best research evidence with clinical expertise and patient values. So what you do is you go and look at the research and then you bring it into your practice, and that's actually what it's all about. The other definition for it's the conscientious and explicit and judicious use of current best evidence in making decisions about the care of the individual patients. So think about what you do in your practice. You've got clinical information which comes from the case history, the examination of your patient, and then some other investigations you do. And then you also have valid information that you get in from papers or from textbooks or wherever you need to go and look. But you have to be up to date with what's going on in the world of practice. So on average, if you think about clinicians, when they sit with a patient and they have to make some decisions for the patient, they normally have about 2 to 3 questions per patient that they ask. And the first one is related to the fact: what type of drugs you're going to use, what's the dose, what's the side effects. The questions about your diagnosis or the diagnostic test accuracy, specific questions about management options and prognosis, and all of these answers to the clinical questions are sought in a variety of ways, which includes your textbook, as I said, journals, referred to colleagues or specialists, or people can do online searches. So the practice of EBM requires the application of a process that includes 5 steps typically. First of all, you formulate answerable questions. You track down the best evidence wherever, from, say, the internet. You critically appraise this evidence, and you individualize the evidence based on the clinical expertise and the patient concerns. And then you evaluate your effectiveness and your efficiency, and you keep a record to improve the process. Right, so the uptake of evidence-based medicine is not an easy thing, because there's an effort to learn and there's an effort to use it. And then you have to balance this against the perceived value of this evidence-based medicine that you're trying to implement in the practice. So some of the older guys don't like to go and sit and attend CPD lectures and blah, 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 because they feel it's a waste of time because they know everything. So the effort is quite a big, barrier, and then the perceived value. So if you don't perceive value from learning something, you're not going to do it. All right, so from this book of Diffusion of Innovations, there are 6 factors that influence the uptakes of innovations such as evidence-based medicine. What's the first one? Is the relative benefit. What's in it for me? Everybody will ask that. Is it complex? Is it easy to learn? Can I trial it? Can I try out easily? Is it observable? Can I see my colleagues doing it, or my colleagues or our peers doing it? Is it compatible? Will it fit with the ideas and work I do? And can I adapt it to my practice or my environment? So the relative benefit, what's in it for me? What can evidence-based medicine do for you as a practitioner? Well, first of all, it will reduce your reading because you're going to use quality filters. So you're going to start lowering your Jasper score. And the next slide will discuss what Jasper score means. You'll better manage your patients. You'll improve your job satisfaction by making better decisions. And lastly, you'll relieve anxiety because of uncertainty. You can avoid shame when your patients seem to know more than you know because of Google. All right, so the Jasper score is something called a journal-associated score of personal angst. Now, at the bottom there, you'll see there's a score of 0 to 5. And if you're honest with yourself, rate yourself. So the J stands for, are you ambivalent about renewing your journal subscription? So it's about journals. Do you feel anger towards prolific authors of journals and the journals? Do you ever use journals to help you sleep? I sometimes do. Are you surrounded by piles of periodicals and journals which you never seem time to get to read? And do you feel anxious when your journals arrive? So you can score yourself at 0 to 5. If you get 0, I think you're a liar, because most of us have some anger and angst towards this. 1 to 3 is in a normal range, and more than 3 is sick. You're at risk of something called polycythemia gravis and related conditions. So let's talk a little bit about polycythemia gravis. This is the downside of EBM. So have a look at what happened to a senior physician, and senior read older, who fractured the neck of his femur. One night of the accident, what he did is he obviously he's got some prostate problems, so he got up to go to the loo, and then he stepped on a pile of journals which were still in their plastic sheathing, and he slipped and he broke his femur. So he felt an increased sense of guilt and inadequacy associated with the inability to keep up with the journals he had to read. His JASPER score was 5, which is consistent with the amount of journals kept by the bed, avalanching both under the bed and across the room. In his case, the oldest journal in the pile was nearly 5 years old, and the cumulative index, or journal cumulative index, is about 100. His orthopedic surgeon was very happy with his progress, so he made an excellent recovery from his broken femur. But paradoxically, there was a significant improvement in his JASPER score because he changed the way he looked at these things. So why have we got all these problems? Have a look at the size of medical knowledge. 875,000 or more concepts in medicine. 2.14 million concept names. 11,000 diseases. If you cover one disease per day, it'll take you 30 years to cover 11,000. 30,000 abnormalities, symptoms, signs, and labs and x-rays. 3,200 drugs. Okay, 18,000 products. So William Osler says to cover the vast field of medicine in 4 years is an impossible task, which you're obviously aware of. And the same happens with optometry. Have a look at what's published in the world on a fortnightly period. So if you look at biomedical journals, there's 5,000 journal articles per day published in the world, and Medline 1,500. In trials, there are roughly 95 trials per day. So you're going to now start seeing how hard it is to keep up to date with what's going on in research. So will you ever sleep? So to keep abreast of all medical advances reported in the primary journals, a general practitioner will have to study 19 articles per day, 365 days of the year. And put a different way, a clinician who studies for 8 hours per day for 5 days a week will only be 4 weeks behind after the first week that he started doing this. So in essence, there's a huge pile of information that we may not get to be able to read, and we all know that. The next thing with evidence-based medicine, which is of concern, is if you look at this chap, Ioannidis, he reports that over 50% of peer-reviewed biomedical science is rubbish. So a lot of the information that's put out there for us to read in the journals is really nonsense. So the probability that the research claim is true depends on a few things: the study power and the bias, the number of other studies on the same question, the ratio of true, no relationship among the relations probed in the scientific field, and the size of the study. So you have to be very careful what you read. And later on, I'll refer to a book by somebody by the name of Trisha Greenall, which will teach you how to read, papers. Then the other guy that I also admire a lot is Ben Goldacre, who's a GP or general practitioner in the UK, and he sort of takes on all of these false claims. And he says, trials with a positive outcome, this means that it's random control trials with positive outcomes are double or twice more likely to be published than trials with negative outcomes. So we're not really getting the true story from research. And things like flawed studies, such as the MMR, vaccine, and autism, all of those things play into this. So you really have to be careful what you look at and how you look at the research that you use. The next thing that's important is to find out which type of journal articles to look at. So if you look at this pyramid, you can see at the top of the pile is systematic reviews and meta-analysis. That gives you the best information. Below that's randomized controls and double-blind trials, and then it drops down to at the bottom here, which is ideas, editorials, and opinions. So be selective in what you choose to read. So the next step in actually accepting evidence-based medicine is non-complexity. Is it easy to use? So if you look at this little diagram at the bottom, the direct line is much clearer than all the other little lines going around. So let's have a look at that. So you have to simplify your critical appraisal of these things and use the two mnemonics method. That's what I like doing. So what question did the study address? And that's the PICO method, which we'll go into more detail about. Were the methods valid? And that's the Rambo method. So let's just highlight that. So the appraisal or the PICO method here, what question did the study address? For example, if you look at the study on amblyopia and patching versus exercise, what was the population? Was it children under 5 years with amblyopia? Intervention, did they use eye patches? What did they compare it to? Eye exercise. What was the outcome? More effective in increasing visual acuity and effective eye. So you can use this to sort of very quickly scan through the study and see if it's worthwhile reading. Then you appraise the thing. Was the study valid? Look at the recruitment. Who did the subjects represent? Is it people that you're going to deal with? Or is it some weird population that they pulled out from somewhere? Allocation. Was the assignment to the treatments randomized? Were the groups similar and the trial start? Maintenance, were the groups treated equally? Were the outcomes ascertained and analyzed for most patients? Measurements, were the patients and clinicians blinded or treated? Or were measurements objective and standardized? And then look at your p-values and your confidence intervals in that specific paper. That helps a lot. All right, and then finally, here in this section, a common sense approach is good. Always search for secondary literature first. That's clinical guidelines. The TRIP and the PubMed databases are good. But some of these are based on consensus of research is inconclusive. Systematic reviews or meta-analysis are preferred. And then after you can't find anything on that, then search for the primary literature in individual clinical trials and apply your PICO and Rambo methods. There's some search engines which are worthwhile using. One of them is the Cochrane database. Go and look at their site. That's a really good thing. They do systematic reviews, which is fantastic. And you can have, they've got a specific site for eyes and vision. The Oxford Center for Evidence-Based Medicine, very good. Turning research into practice, the TRIP database, PubMed. And if you do use Google, use the Google Scholar website, because then you filter out all the rubbish that are out there. All right, so the next step is trialability. Can I try it out? How can we make EBM easy to try? So you have a paper question log, you answer a few important questions every week, get help with your searches, speak to your colleagues, simplify your appraisal or use pre-appraised topics and focus on interpretation. And share with your colleagues, is this thing observable? Case-based journal clubs, CPD meetings, which is similar to what we are doing here today. Do some case presentations amongst your colleagues and discuss the papers you read. Publication of interesting cases in evidence-based journals or online, and share your critical appraised topics with others so that they can also give some input. And compatibility. Now, this specific study after a review of 23 studies says integrated teaching is best. So when you have real patients and current problems, this results in better knowledge, skills, attitudes, and behaviors. And you can see the results of the study with integrated teaching is outperforming the other way of teaching, the standardized teaching method. So try and integrate your teaching into your practice with real patients and current problems. And finally, can we as practitioners adapt to evidence-based medicine? So yes, we can, but use your own question and issues, learn at your own pace, use and familiarize yourself with your own tools, printed format, find out which electronic format you want to use, choose only the relevant information and adapt your skill set to this new information. And also be aware there's many leaks from research to implementation and practice. So if you look at that little scale there, there's the different steps research goes through: aware, accept, target, doable, recall, agree, and done. And if 80% is achieved at each stage, you're only going to implement about 21% of that research into practice eventually. So remember all the leaks along the way, when valid research gets published. So in conclusion, evidence-based practice involves learning how to use and retrieve evidence from ongoing research, systematic reviews, meta-analyses, and random controlled trials online. Then you evaluate the quality of the evidence retrieved, and finally, you incorporate the evidence into your clinical practice. Here's a very, very helpful website. I'm not sure if you guys are aware of this. This is a Russian lady that had enough of paying for journal articles, and she set this website up to crack them. So what you do is you just pull your DOI or your PMID into that little slot there. You press open, and it cracks that article, so you don't have to pay $28 every time you want to read something. So be aware also that this website's closed down every now and then by the big players. So just remember, she changes the URL a little bit, but you'll find it if you look for it. And then some recommended reading. The book I spoke about on the right-hand side is How to Read a Paper, and that's by a lady by the name of Tricia Greenhalgh. I think the British Medical Journal will have a set of articles that you can download for free, but have a look at this. This will systematically teach you how to read a paper and not waste time. And then a book that I really enjoyed is Bad Science by Ben Goldacre, who refutes all the hairy-fairy theories and stuff going on. He always has a good go at the homeopaths as well, which I really enjoy. So that's my story. Any questions? Thank you.
Thank you, Dr. Dirk Booysen. You really expressed the importance of upgrading yourself regarding the advancement in the optometry practice. It is really important that a doctor upgrade himself and that will finally benefit the patient. It was great listening to you, sir. And if you have any question for Dirk, I would like to request the participant to write in the chat box, or if anybody would like to ask him, say personally, if there is any question.